Lovely. So welcome everyone to our event this afternoon. I'm really excited about having such a fantastic panel of speakers join us, including Councillor Joanna Midgley and Professor Sheena Cruickshank and Dr. Ruth Bromley. So before we start, I want to do a bit of brief housekeeping. We're doing the meeting on Zoom, and we'd appreciate it if you could all stay mute for the presentation section. When we come to the Q&A, we'll ask you to put questions in chat, and we can bring people in to join the discussion then as we move through it. We are recording the lecture, so obviously if you don't want your face recorded, please turn off your videos. We will also be using closed captions, so we hope that will benefit people who enjoy closed captions. And the final thing is that people may well share personal stories during the event, so please be respectful of those as we move through. So I'm Stephanie Snow. I'm the academic lead for patient and public involvement for the Faculty of Biology, Medicine and Health. So I'll be chairing the event this afternoon and also sharing with you a bit of the work that we do around inclusive practice in our patient and public involvement forum. But first, I'd like to introduce our speaker, Joanna Midgley. She is the Deputy Leader of Manchester City Council, and since May 2021, she's been the Executive Member for Health and Care. I'll just stop my screen because I know Joe's got some slides. So Joe's portfolio includes homelessness, domestic abuse, promoting the safety of women and girls, asylum seekers and refugees, the voluntary and community sector, anti-poverty work and tackling inequalities. She's involved in many local community groups, and she's currently trustee of Chorlton and Disbury Food Bank, chair of Barlow Moor Community Association, which is based on the Merseybank estate, and a school governor at Chorlton Park Primary School. So I can really think of no better person to really open our discussions this afternoon. So Jo, over to you.
Thank you, Stephanie, and thank you so much for inviting me. It's a real pleasure to be here. So as you can see from my portfolio, yeah, I've got quite a range of issues in there that are linked to tackling inequality and poverty. And so I've been covering those issues since last May. I was exec lead for health for the year before that, so I know a little bit about the health stuff as well. So I'm going to give you a little bit of an overview really of inequalities in Manchester and some reflections from my time on the council and how we are tackling inequalities and our plans for the future. Obviously it's a pretty huge topic, so I've kept it quite broad, but obviously I can pick up on things in the Q&A if you feel like there's something you want me to go into in a bit more detail. Okay, so I'm just going to start off by setting the context of the city. So Natalie's very kindly doing the slides for me because I was a bit too scared to talk and be in charge of slides in public. So can you press the next slide, Natalie, please? Oh. Is it not working? Oh, it was working when we practiced. Oh, and if you press it again, the text will, that's lovely, thank you. Okay, so so basically we have a fantastic city. I'm sure we're all aware just how diverse and wonderful Manchester is, but we're also a pretty kind of fast growing city. So the figures from the recent census show us that our population's increased by 165,000 in the last 20 years. And we're also a relatively young city as well. So the biggest age cohort is our 20 to 34-year-olds. And our BAME communities have grown as well from 33% to 43% in the last 10 years. So, you know, we are a brilliant city. We're really diverse and we love welcoming people here, whether it's to work, study or to seek sanctuary. And if you're interested, there's loads of really interesting data from the census on the government and Manchester Council website. If you can press the next slide, please, Natalie. Thank you. So I'm not going to go through all this in detail, don't worry. But again, just to kind of reiterate that point that about our diversity. So 1 in 3 of our residents was born outside the UK. We think we've got about 94 languages in the city. And I went to a presentation recently with young people, and one of our schools has got 93 of those languages in their school, which is amazing, isn't it? So it just adds to that real feel of kind of, you know, diversity and inclusion. So having all this information is really useful, obviously, because it helps us to plan our services and make sure that we're delivering services in the right way to people. But we know that different communities have got different experiences of accessing the services that they need, and I'm sure we'll pick up on this later, but particularly health and care services, because we know, for example, that from looking at the registrations, that not all people from all ethnic groups are probably registered with a GP, for example. And those kinds of barriers include things like language, culture, awarenesses of what services are available, and also trust in services as well. So though that inequality of access in health is a really important one, and maybe other people are going to pick up on that during this afternoon. So the earlier we can intervene and make our services more accessible, the better, because obviously if people don't get the right healthcare, then that leads to more inequality down the line, or if they don't get the right advice about benefits that they're entitled to as well, things like that. Okay, so if you want to just press the next slide, Natalie. Okay, so at the moment, there are lots of challenges. I'm sure we're all aware of this in Manchester. So we've got, over the last 20 years or so, I mean, I came to Manchester to study at what was then the Polytechnic back in 1983, and Manchester is kind of unrecognisable from those days. We've made such huge developments. You know, the town centre's completely transformed. Ancoats is a completely different place. I didn't recognise it when I went there the other weekend. So there's been some fantastic development, but we need to recognise and be quite honest that a lot of our residents haven't benefited from that, or haven't felt the benefits of that. So I think what we want to do as leaders of the council is really make sure that we promote our work, the work that we're doing on inequality, and put it kind of front and center of all that we do, because we want the city to be a place where everybody can prosper, can reach their potential, and can enjoy the city that they live in. But there are huge challenges, as you can imagine. So there are some of them here. So, for example, I'll come to the cost of living crisis last, I think. But I think before COVID, we were really acutely aware that health inequalities were really serious in the city. So, for example, if a male born in the north of the city, from the moment they're born, we know that they're going to live probably about 8 years less than a male who's born in, say, for example, Didsbury. So the average life expectancy for the most disadvantaged fifth of Manchester is 70.9 years. In the most advantaged areas, it's let me get this right, 76. I've got that wrong, sorry. The difference is 8 years anyway for males and 6 years for women. A lot of that is caused by, you know, things like smoking, heart disease, lack of exercise. A lot of those deaths are preventable, and we can do something about them. But a lot of it is due to poverty as well. Manchester is the 6th most deprived local authority in England, so we have a really big problem with poverty and income and debt. Over 40% of our children are living in poverty, and 1 in 3 are not school ready by the time they start reception. And that's been made worse by COVID, of course, because a lot of children have just been at home without any kind of social interaction. So there's some real issues there. In terms of housing, we are in the middle of a housing crisis, and we've got over 3,000 people living in temporary accommodation in Manchester, which is the highest it's ever been. I don't know if you saw on the news last night, the rough sleeper head count has increased by 25% nationally. In Manchester, it's increased about 20%, but we were really disappointed in that, because we put a lot of effort into getting rough sleepers off the streets and into accommodation, but we see those figures creeping back up because of the cost of living crisis. A lot of people live in poor quality housing that's privately rented, and because rents are rising, many people can't afford the rents in the private sector. I don't know if you're aware, but the local housing allowance, which is the money that people get from the government from their universal credit to pay rents, has not increased for about a decade. So as rents have risen, but people haven't been given the money to keep up with that. So we're seeing a lot of Section 21 evictions and things like that in the city, because rents are rising and people can't afford to pay it. That if the government could do one thing tomorrow to ease the housing crisis, then that would be the one, to raise the local house allowance. So we face a really big problem with housing in the city. We are doing our best to meet that demand. We've committed to building 10,000 people homes in the next 10 years, but it's a real challenge at the minute. Okay, so other issues or other challenges that we've got at the minute are, of course, the cost of living crisis. So we just came out of COVID and then straight into another crisis, which is the cost of living crisis. So we did some research at the end of last year, and we estimate that in the city, I think it's 23% of our residents, once they've paid their rent, fuel bills and food bills, have about £30 a month to live on. So if you kind of imagine, you know, having to buy your kids shoes, pay for your travel, I mean, to me that is you know, unimaginable to have to manage on £30 a month. But that is the reality for about 23% of our residents. So we know that a lot of residents in the city are struggling, and we have tried as a council to put money into supporting that. So, for example, we've put £8 million of investment in to supporting our vulnerable residents, and we've worked out which wards in the city are most affected. There's 11 of them that are really badly affected. So we're trying to target our resources into those areas where we can. And we passed our budget actually this week on Friday at council, and it's another cuts budget. I think it's the 11th year in a row. I'll come on to that in a minute. 37 million over 3 years, but we are still doing our best to invest in this kind of agenda. So we're putting another 3.5 million out of reserves into the cost of living crisis to try and improve things like debt advice, support the voluntary and community sector. And we also have, we set up a cost of living advice line as well, where we're trying to signpost people, you know, and make sure that they've got somewhere to go if they're struggling with cost of living issues. So I suppose, being a politician, I suppose, if you'll just allow me to be political for a minute, you know, poverty and inequality is political, isn't it? Because it's the result of political choices and political actions. And as a city, we're suffering. We're all suffering the impact now of, I keep losing track, is it 11 years of austerity? And this idea that austerity is over just isn't true, because the cumulative impact year on year of cuts has an impact on people. It has an impact on the services that we can provide as a council, and it's been really, really difficult for the last 12 years or so. To put it into some kind of perspective, our council spending power is about £420 million a year less than it was in 2010. So if you add that up year by year, one of my colleagues said the other day that it's about £3 billion, and that would be, you know, could buy Manchester United with that possibly. Not that we'd want to, but it's a huge amount of money, and it's so frustrating that we could do so much with that money if we still had it. And I know that, you know, austerity was probably always going to happen, cuts probably did have to happen, but it's the way those cuts have been dealt. So if we'd had the average cut in Manchester, we'd still have £70 million a year more every year to spend on our residents. And that is, you know, that's really hard to take. Anyway, I'll stop being political, but it is, isn't it? Because ultimately it's the choices we make for the residents of our city and our country. But as a council and as leaders of the council, we want to make sure that we try our best to invest in our residents, and our vulnerable residents and support them through the cost of living crisis. So we've got some tough times ahead, as we all know, and you know, we do want to do all that we can to address the inequalities in the city. Sorry, I digressed from my script, going all a bit political there, so I've lost track of what I was saying. Should we go on to the next slide? Okay, right. So yeah, do you want to press it again? I think some text should come up. So as a city, we like strategies. I think we've got about 50 of them, but this is the main one. It's the Our Manchester strategy, and it's like the overarching kind of strategy for the whole city. And our 5 main priorities are achieving a thriving and sustainable city, a highly skilled city. We want to provide opportunities for people to, you know, get a good education, a good variety of jobs, train, etc. We want it to be progressive but equitable. It's really important that we address the zero carbon and the climate change, and that we're connected so that people can move about to jobs and you know, things like that as well. So that's our Manchester strategy, and that was devised from listening to residents. So we didn't just come up with that ourselves. We did do lots of consultations with residents, with businesses, with partners, and every year we make sure that each of our directorates, all their priorities are linked to those key priorities. So do you want to go to the next slide, please, Natalie? Thank you. So the quote on the yellow slide there is, "Our future Manchester will be a place built by all of us," and that came from a resident of Manchester who responded to one of our consultations about the strategy, which I think is really lovely, isn't it? And we do want to make people feel that they are part of the city and that they have a stake and a say in it as well. So the second thing on there is our Making Manchester Fairer programme, which is our kind of one of our key aims at the minute. We, after COVID, you're all aware of Sir Michael Marmot's work. He wrote the Build Back Fairer in Greater Manchester report, and we've been working closely with him about how we can kind of really tailor that to Manchester. So what we've come up with is his key recommendations, just tweaked a little bit, and we've kind of renamed it Making Manchester Fairer. So this is a system-wide approach to reducing health inequalities in Manchester for the next 5 years, and it's about getting everybody to work together, not just the council, but you know, our health partners, businesses, VCSE sector, etc. We're trying to get everybody across the system involved in this piece of work, and it covers all the socio-economic determinants of health, housing, employment, and poverty, and education as well. So, because the only way that we can really tackle inequalities is by pulling together and working together to make progress across the system. We can't do it as a council on our own. We can do bits, but we have to do it together collectively across the city. So do you want to go on to the next slide, please? So it's a bit small, that, but basically those are the kind of the 8 key points of the Making Manchester Fairer framework that we are going to be delivering on. So this is fairly early days. We launched it, I think it was last autumn. I'm going to be chairing the board of governance for it, along with my colleague Tom Robinson, who's the exec lead for health. But if you can see that small writing, basically we're going to focus on early years and young people, poverty and income and debt, work and employment, preventing ill health and preventable deaths, housing, places, transport and climate change. And the one we've added, and that is really important here, is systematic and structural racism and discrimination, because that is so important into making sure that our residents get access to the services that they need in order to combat inequality and to live good lives. And Communities and Power is about hearing from our communities and making sure that they have a voice and a stake in how we move forward. So basically, that's the framework. We are aiming to address all of those. It's pretty ambitious, but it's also really exciting, and we've had lots of kind of commitment and buy-in for it. I think we all realise we're at a bit of a crossroads. Really, we have to act. We know what the data. We have to do something about it now. We can't just sit about and talk about it forever. We need some really clear actions. So we've got some what we're calling kickstarters to try and actually put something really kind of concrete into practice as soon as we can. So one of those is about young people, like you know, as I mentioned before about the effects of COVID on young people and early years and schools. We're doing a really kind of intense piece of work on that to try and bring those really young children up to speed with coping with school. Yeah, and so sorry, one of the other big things that I didn't mention actually with the structural and systematic racism is about really trying to bring about trust in services, you know, and through COVID we realised we had a really good piece of work in Manchester called COVID Health Equity Manchester, where we reached out to groups, and I know that the awful term hard to reach groups, but groups that didn't normally engage with us in the community, and we've got some really good sounding boards within communities now. And one of the most important things that we've kind of learned really is about how we need to really gain people's trust, so that they will come to us, engage with us, so that hopefully, and we can listen to them, and then hopefully we can put things in place that really do tackle the barriers that they have, and therefore address inequalities. Okay, do you want to go on to the next one, please? Yes, so this is just a few examples of things we've been doing recently about addressing the cost of living crisis. We've got a really fantastic food partnership board, which kind of grew. A lot of the things actually grew out of COVID in a way, because we had to respond really quickly to supporting people with food during COVID. But that, I mean, it's sad, isn't it, really, that we still need it, but we do, because people need support with food during the cost of living crisis. But we've got a really good system in place in the city that we are supporting as well with £1 million of council funding next year. I mentioned our COVID Health Equity Manchester work, which is still ongoing, and we're giving out grants to small community grants through that to combat the cost of living crisis. And that's some information about our cost of living helpline that we opened in October and gets about 100, I think we're getting about 120, 150 calls a week. But what we can do, the main calls as well about debt advice, which is becoming increasingly an issue in the city, and about support for food. I mean, I can talk more about that, but there's so much to it. That's just a flavour of what we're doing at the minute to combat the cost of living crisis. Do you want to go on to the next slide, please? So yeah, just a slide to say, and then we have to be really honest here, that obviously the council workforce has to be reflective of our communities in order for that trust that I talked about, and it hasn't always, and we realise that. So we launched in 2021 a workforce equality strategy to try and make our workforce more reflective, especially in senior leadership. So that's been going really well. We've set up some schemes, a new leadership pathway for Black, Asian and minority ethnic colleagues, including one specifically aimed at women. And I think, yeah, of 47% of people who completed that have gone on to secure promotion within the council. I chair a monthly meeting of a kind of cross-council directorates where we talk specifically about the workforce equality strategy and, you know, make sure there's some ownership and accountability of it. It's a really important piece of our work, because we want to be a council that is reflective of our city, and we want it to be a place where people can really, you know, flourish and we can use all their skills. Okay, so that's just a little bit of an overview about what we're doing in the council as well. Do you want to go on to the last slide, please? Oh yeah, sorry, that's questions. I finished. I feel like that was a bit of a kind of a rapid run through. There's so much I could say, but I don't want to talk forever, so I will pick up questions when we come to the Q&A. Thank you.
Okay, thank you, Jo. That was brilliant to cover so much in your allotted time. And I can see we've already got some really interesting questions in chat to start picking up when we get to the Q&A session. Anyway, I want to move now to bring in Professor Sheena Cruickshank. Sheena is a British immunologist and professor in biomedical sciences and public engagement at the university. And her research is into immune responses of the gut as started as a result of infection and or inflammation. As well as all the scientific research that Sheena does, she's also an award-winning science communicator who involves diverse communities both in the UK and Africa. She regularly discusses immunology and infection in the media. She's appeared on many programs on this subject. And most recently, she's won the Association of British Science Writers, Dr. Catherine Giles's Award 2021 for the best popular article written by a scientist or engineer. So Sheena, we look forward to listening to you.
Thank you. That's quite the introduction. I feel massive pressure now, and it's worth saying in terms of my research that it's broader than just the gut, and a lot of it involves infections, it involves the lungs, it also involves the response to pollution. And actually, we're doing quite a lot of work around COVID and pollution and things like that as well. And I think it's quite relevant to what we've just been hearing from Joanna. And in terms of equalities, there's been a huge impact there. And I think that the critical thing with research is really making sure that it's purposeful and it's relevant, for me anyway. And because there's so many big questions that we have to tackle now, often that involves more than one head. You know, you need diverse teams to be able to explore that research with diverse knowledge, diverse backgrounds, often different disciplines as well. And I think this is important, that we become better at acknowledging that a lot of what we do in science is incremental. It's based on the work of others. You then, discover a little bit more, others discover a little bit more. And it's all this kind of growing, expanding universe. And it requires so many different voices to actually do what you need to do. Yet, the diversity is not actually recognized in academia, not yet. So it's around, I pulled out some recent stats. So just under 70% of all professors are white males currently. And around 21% are white females, and only 1.7% are Black minority ethnic groups that are actually female professors. And that's absolutely shocking. That does not reflect what we've heard about the community in Manchester, for example, and it certainly doesn't reflect the UK as a whole. And there's a lot more that we can be doing to sort of try and encourage and address inequalities in publications, which are so important to get your research out, but also important for academic promotions. There's more that we can be doing around grants as well. And there's quite a lot of work that's emerged about kind of inequalities around funding and publications. And I think this element of doing good research involves diverse teams, but it is also, for me, it's better if it's informed by the publics that we're going to work with and that are most relevant to the research. And I think this then ensures that you're catering to that community's needs. And that might not mean going to the most easy to reach community. It might be a little bit harder to make that connection and build that trust. But if you do, it reaps huge rewards, because the research enables you to develop a shared understanding between the different partners. It helps build skills for all. You all learn so much. You can identify place-based needs. We're a civic university with a civic agreement, working with communities in Manchester, for example, can be addressing or should be addressing things that the council are needing to do, and what Joanna's just been talking about. It's more diverse, it's more relevant, it can then feed back into policy and help policies work better. So I'll give you some examples of some of the ways that I've done that. So one of the things that we've done is working with parasitologists. We were looking at parasitic worms, and these aren't so common in the UK. And there was we were really interested in talking to people who had more primary experience of those parasitic worms. And so we looked in the UK initially, because of course, as we've just heard, we've got a lot of people who've moved to the UK who are, you know, first, second, third generation immigrants, or at least they were immigrants. And it was quite fascinating reaching out to that community and working with that community here in Manchester, because despite these infections being amongst the most prevalent in the world, and actually incredibly prevalent in some countries that they came from, there was a real lack of awareness of how significant the infections were. There was a real perception that these were dirty and something they should be embarrassed about, when they're as common as catching a cold in the UK. And one of the things that really came to light was there was this huge barrier with medical English and scientific English. And that was really reducing any kind of ability to have a meaningful dialogue. And I think this speaks to the fact that Janice has been talking about, the fact that we know that there are real issues around accessing healthcare and addressing healthcare needs. And I think language is definitely one of those issues. And of course, we've heard how many languages that we have. So one of the things that we did as a result of that was start working with English teachers to start to develop infection awareness classes that would teach the dialogue and teach you how to use the dialogue to then be able to have more sort of explorative questions around the research. And so we've been doing that for quite some time. They run independently of me now, and they run Bolton College with whole generations of learners, all sorts of ages, have accessed them. And they then use those to go back to their communities, because we've done long-term evaluation, and they're doing things like vaccine advocacy work, because they understand how vaccines work. They feel confident and empowered about the immunology of the vaccines to go back and do that work. It's also, for me, led to papers, which is great. And it's identified new routes of research and new partnerships for research. And one of the things that was really striking working with those communities was that they kept talking about allergies. So as somebody whose son had been recently diagnosed with asthma, I was quite curious about the fact myself why so many people were getting allergies. And that was something that was really increasing. So this is something that I looked at doing. But the other thing that I looked at doing was working with medical students to start taking what we've been learning from Bolton and applying it in the field in Madagascar. And in Madagascar, what we were looking at was a very unpleasant parasitic infection called schistosomiasis, which is a waterborne infection primarily. And these medical students were out assessing how common it was. And there was a 94% prevalence of this infection in these really small villages in Madagascar. And they weren't getting any kind of treatment for it at that time. But because we partnered with policymakers in Madagascar, the health minister, we were able to get that treatment out to those villagers. But if you've got a heavy infection and if you take the drugs, it's not very pleasant. It doesn't make you feel very well. And you have to keep taking the drugs regularly for it to get the sort of sustained effect. So it was important that we did a sustained education campaign there. And we worked with villagers, we worked with village leaders and teachers to develop that, learning what we'd taken from the ESOL lessons that we've been doing back in Bolton, and even using some of the same resources, but applying them to that context in Madagascar. And this had a really great effect. So we saw an increased uptake of the drugs that were being offered from 61% to 89%. We saw more use of latrines rather than, I'm afraid, open defecation. Going to the loo in the open is a bit of an issue when you haven't got running water. And that was one of the things that was causing this sort of cycle of reinfection. So we saw more use of latrines, decreased open defecation, and much more increased confidence in disease and transmission. And we've published a number of papers from that study. And then going back to the allergy question, we've been working with computer scientists, data analysts, environmental engineers, geographers, and we've done everything from developing participatory citizen science research to look at the incidence of allergies and the different environmental factors that help drive that. And we literally had a paper published on that last week. We've been working with residents in Ardwick to look at how pollution is affecting them and looking about what we can do to try and enhance active travel. We're actively doing that right now. And I think this just shows you how your research can evolve, but all the way through, this has been informed by, involved the public, but also incredibly diverse teams of research, because there's no way that one immunologist could ever do this. So it's teamwork from public and teamwork from researchers.
Thank you. That was great. And it just shows, doesn't it, you know, what an opportunity we have being in Manchester, based in Manchester, with our local populations and communities that are actually experiencing and having links to so many of the real world problems sort of further afield. So that was great, and I'm sure we'll get lots of questions coming on that. I'd now like to move on to Dr. Ruth Bromley. Ruth is a very proud GP, an academic with a lot of experience as a senior healthcare leader. But I think the work that she's probably going to share with us today has been around tackling health inequalities, particularly as the clinical lead for homelessness in Greater Manchester. And in that role, she's worked very closely with the Mayor of Greater Manchester, Andy Burnham, and together they've been fostering a holistic approach to tackling homelessness, which encompassed understanding the impact of psychological trauma upon adult behaviour. And I think this will link really nicely to some of what Jo was talking to before as well. So Ruth, we look forward to listening to you.
Thanks very much, and thanks for having me here. So yeah, Joanna and I have worked very closely together over recent years, so there's a lot of parallels. So I'm not going to repeat the things that she shared, although I have been part of a lot of that work over the last few years. But for me, health inequalities are my own personal portfolio. It's where there's the harmony in what can sometimes be a bit of an eclectic career. So I'm a GP working in Wythenshawe. I've worked across the whole of my community over my 20-year GP career, but I now work in one of the most deprived parts of Wythenshawe, and most of Wythenshawe scores very highly on deprivation indices. So I have sort of first-hand day-to-day experience through my patients' lives of hearing the impacts of deprivation and seeing complex comorbidity in young people, so people younger than myself who will have multiple chronic health conditions, which will ultimately shorten their lives, but also mean that they live many years in ill health, which is another sort of way of measuring the health of our populations, is how many years people live in good health. So this brings it all together for me. So I've been involved in the national narrative. I'm really proud that we've moved the narrative on nationally over the last 2 decades. You know, I know that some of the national policies can be mocked, but even the fact that we are having the conversation and there is ministerial time given to inequity is a win, when, as Joanna says, we've had the data for a number of decades. So we should move with the fair wind that we've been given, but we work in complex and hierarchical systems, and you know, behaviour and culture has a lot to do with how we progress forward. So the question in my mind constantly as the commissioner was, what does this mean in practice? And of course, one of the things we have at the university is lots of budding healthcare professionals, and they're incredibly passionate and enthusiastic, and they come to Manchester with lots of good reasons. So we've very much underpinned our training over recent years through the Aristotelian principles of giving the most to those who have the greatest need, which fits very nicely with some of the national sort of directive and very much the work that Joanna and colleagues are trying to do in the council. For us as doctors, obviously we have a very strong emphasis on doing no harm. So there's a lot of debate about where does harm occur, how do we mitigate harm, how do we minimise harm, and thinking about the ask of the patient constitution to allow our patients to live, you know, whole lives and to be valued for everything that they bring into our consulting rooms, but more importantly, everything that they want to do and how they want to live their lives in their communities. So there's been a real focus for us on intersectionality and compounded deprivation, and we can look at any group as an individual entity. So I guess we're here because of International Women's Day. So, you know, there would be focus on women's needs, but of course, within any group of women, there'll be people with learning disability or learning difficulty. We may have people from LGBTQ plus communities, and obviously a whole range of socio-economic sort of backgrounds. And I think probably that latter group is the one we think about least in board structures. And if I was to push for one further thing today, it would not just be looking at visible diversity, but it's knowing about people's poverty backgrounds and making sure that there's representative voice, you know, in positions of power where people who live with poverty or who have experienced or are experiencing poverty are heard. And I do see that coming through in the council's strategy moving forward. So some really tangible examples for you. I'll just sort of rattle through them, but we did a lot of work around paediatric asthma. Interesting that you mentioned that, Sheena, but if you are a child living in poverty, then you're 2.5 times more likely to be admitted into hospital because of your asthma. And we have a lot of deprivation in our city. So the children with asthma that we see in our hospital settings may be more likely to be experiencing poverty. So what we're trying to get our learners to do is to see the demographic context of that presentation. There is no good in assuming that that person is going back to a warm, you know, heated house with good, healthy food in the fridge and sleeping in their own bedroom with some kind of air purification going on, because that often isn't the case. And we saw that in COVID, when people living in crowded accommodation were much more likely to contract COVID on multiple occasions. And of course, very sadly, that paralleled with people from minority ethnic backgrounds a lot of the time. So it's really thinking about those intersections all the time, but remembering poverty as one of those intersections. So we've done adverse childhood experience training across the whole city. We've trained all of our frontline practitioners in general practice to understand the impact of emotional and physical trauma, as well as sexual trauma in people's childhood, the impact on their adult health and well-being. And that's very important when we think about people who've experienced homelessness. But actually, in my population and within Shore, between 30 to 70% of people will have had some form of abuse throughout their childhood. And of course, abuse in childhood often means that people develop behaviours which make them much more vulnerable to perpetuated trauma in adult life. So the understanding that trauma alone will shorten your life expectancy, trauma causes COPD, trauma causes heart disease, really getting our learners to think about that whole continuum of the life, understanding the story and the presentation today in the context of previous experience. And that all builds on using stories, really feeling passionately about wanting to get to know our patients and who they are and what matters for them. We've written a health inequality strategy in medical education, which we're working through. There's a lot within that. There are colleagues within the medical school much more experienced in some areas than me, thinking about asylum seeker and refugee healthcare, thinking about racism and the impact of racism on people's health. And for that, we think about it both for practitioners and for patients. And often our patients are also healthcare practitioners, because a large number of people in our city actually work within the NHS. But the racism in the NHS was exposed very sort of explicitly during the COVID pandemic again. So understanding the impact of a life experience of racism on people's health and well-being, knowing that our students have also often experienced racism, and thinking about how that impacts on the environment that we work in and how that causes harm to patients. But my part of the health inequality strategy has all been about LGBT affirmation. So we've neutralised our pronouns, we've moved away from more heteronormative examples for health. We're doing a big project, which we're in the 3rd year of 5, working in collaboration with LGBT Foundation and our partners at Indigo Healthcare. So it's a co-produced model. We use peer experience and peer learning, but to absolutely make sure that we're being representative of our demography and our background population. And of course, something that many of us in Manchester are proud of is that at least 10% of our population would identify as being from LGBTQ+ backgrounds, and it's often a reason why our students choose to come and study with us. So we must celebrate that aspect of a patient's lives if and where it's appropriate, without overemphasising perhaps those elements of people's lives at every consultation. So there's a real sort of style and subtlety around when it's important and when it's not, but understanding, for example, that if you're a trans woman receiving prostate healthcare, it's very traumatizing to have to walk into an ostensibly male environment when you're living your life as a woman. So lots of things that our students can learn about that. Loads of stuff about home as healthcare, the health conditions all our students learn about, but it's understanding how to engage with people who can lead challenged lives, people who have been abused, people who struggle to fit into, conventional structures, and understanding the flexibility of communication and empathy and compassion that we might need when working with people, particularly those street sleeping. But as Jo said, we've got a lot of people in temporary accommodation across the Northwest as well, and that adds further complications for both families and children. Two final things that I'm very proud of. I was a co-sponsor to the Poverty Truth Commission, and I'm really pleased to see it referenced still in some of the council documentation, but we made a commitment, nothing about us without us. And so everything that we talk to our students about is taking that first-hand narrative from patients and working flexibly to create a plan that works for any given individual. And then the joy bit is some work that we've done nationally, working with Lord Howarth. I'm part of a National Centre for Creative Health, looking at how we can use creativity and the arts to bring joy and healing and flourishing and well-being, going full circle back to Aristotle. And I'm a trustee for Home in Manchester, and we have a really sort of strong desire to bring joy and happiness to our workforce so that we can create healthy practitioners who will stay with us throughout the 4 or 5 decades that are expected of them now, which is another way of hoping to contribute to the improved health both nationally of patients, but particularly for our communities here in Manchester. So I'll stop there. Thank you.
Thank you, Ruth. That was really fascinating and extraordinary to hear the way in which it's being taken, out into so many different dimensions. And I did love the whole sort of full circle starting and ending with Aristotle. In the interest of time, I'm going to really shortcut what I was going to talk about, because I think what is most important, which draws on what Jo and Sheena and Ruth have talked about, that when we're thinking about questions of equity and inclusivity, it's not just what we do in terms of policies and strategies, it's actually how we translate that into behaviours and practices. So who sits around the table? Who do we go and have conversations with? And there are very simple ways in which things can make a big difference. So, for example, one of my things that I do as the academic lead for PPIE, I co-chair the forum for PPIE for the faculty. Now we have a co-chair, so my co-chair is a public contributor. So that might seem a very sort of, rudimentary thing, but actually visibly that makes a difference, because other public contributors who come to the forum see another public contributor as a co-chair. And I think things like that make a big difference in how people feel that they're involved in that space, the power and the agency they're given in that space, and then what that can lead to. So, for example, something which we're really delighted about and which came directly from a public contributor is that we're now developing a charter mark for PPIE to use across the faculty to really sort of celebrate and mark good practice. Now that has come directly from public contributors, it's not from anyone in the faculty. Those are the sort of benefits that we can get if we really try and put inclusivity into practice in the daily things that we do. So I'm going to move now and ask for questions. We've had lots in the chat already from Mahesh. So Mahesh, I don't know if you want to come in now and, you know, just choose one question that you'd like to ask.
Thanks, Stephanie. The question to Joanna, I mean, my first question was just to provoke about the language. So I'll drop that for now, and choose the second question. In your slide on making a Manchester Fair agenda, I mean, obviously there were different strands to that. So my question, particularly as from our faculty, relates to the health inequality strand. Are there any plans to involve the very large number of students who live in the city? For example, some universities, in our university in particular, is keen to get students, or at least to align the learning needs of our students to the service needs of the community through a suitable service learning framework. In fact, that is now part of our strategy for our faculty. You might know that for years, our dental students have been providing dental care for the homeless people in Manchester. So using that experience, how can we extend it beyond dentistry? And if a proposal of that nature is made to the city, how will the city respond? And who in the city should we approach if we are to go down that route?
Thank you, Mahesh. So we're in kind of early days of launching this, so I think that's a really, really valuable question and offer. And if it's okay with you, if we can exchange emails, maybe I can get someone to contact you and discuss that, because you're right. You know, students they're such an important part of our city. So it's really important that we kind of include students in terms of, you know, what they might be able to, how we might be able to work together, or what we might be able to offer them, and vice versa. So that would be a really good conversation to explore. I'm happy to follow that up with you, if that's okay.
Great.
Is that all right?
That's lovely. Yeah, I mean, just
okay.
to add, Joanna, that when I raised this question with the clinical commissioning groups across the city, when they integrated, I was virtually pushing against open doors. Everybody likes the idea, but the question is, in practice, how do we align it? How do we fund it? So those are the issues. We can have this conversation.
Okay, we'll have we'll take it. Outside, offline, whatever. Yeah. Thank you.
Okay, thank you for that. Ruth, before we started today, you'd suggested a question that I thought actually really sort of brings in a lot of what people are talking about. And that was, how do we encourage those with power to give it away? Do you want to sort of talk a bit more about that and what you think is important?
Yeah, so obviously I've had the privilege over the last few years to work with government and with local leadership, and I think leadership's important, and I think strategy is important, but I think one of my concerns was, as some of the work we'd done through devolution became a national sort of objective, was that it had become work for the middle classes. So we developed a very professional narrative around the importance of worrying about poor people, but that isn't the same as making a difference. So it's a bit about not letting ourselves off the hook, and it's also quite a lot about not allowing this just to become the new work of the professional classes. And I watched the Peterloo film a few years ago, and it just struck me that there's so many parallels to how sort of politics and those kind of governmental machinations worked then and work now. We still have extremely senior figures. It's not to say that anybody isn't extremely well-meaning in taking on those roles, and they're high-pressured roles, but it's about the collapsing of hierarchy and that rapid sort of devolution of resource to the places where it's needed most. And it's also making sure that money isn't wasted. So just to use a very recent example, I spent 2 years talking about ICS transformation with the most expensive, most experienced leadership in the whole of the Northwest, sat in rooms together. Well, if we'd costed out those meetings, and if we'd instead given that money directly to some of our voluntary sector partners working, you know, in one-to-one relationships with our communities, we may have had as much impact as we potentially will have done by going through an NHS transformation in the middle of a COVID pandemic. So I'm probably a little jaded and cynical from some of those experiences, but equally it made me constantly question myself and make sure that I didn't feel I was becoming part of the problem, that handing away power sometimes is the most sort of sensible thing that a leader can possibly do. So yeah, that's the orientation for me.
Yeah, okay, that's wonderful. In the interest of time, I'm really sorry, but I'm going to have to now pass over and ask Natalie Gardner to do a few closing remarks. But I have to say, I feel there's so much mileage that we've had this afternoon and that we haven't had the opportunity to explore fully. Natalie, I think there's a way forward is to develop a series of workshops or think about these discussions and where we could go with them. So Natalie, I'll ask you now to do closing remarks.
Thanks very much, Stephanie. Could you possibly share the slides as well? They're just the final one. But yeah, as you say, and that's exactly where I was going for. I think there's just so much room for more conversations about this and linking up with the council and the university and our students and our service learning, and just how to actually embed and drive social change and what we can be doing and what we can be doing better. I'd like to really thank all the panelists for their contributions today. Joanna, it was a privilege to meet you, and I hope we cross paths again. And Stephanie and Ruth and Sheena, thanks ever so much for everything that you've done. This is sort of the beginning of basically a month of activities around International Women's Day, and I just wanted to draw your attention to some of the other events that we've got ahead of us. Next week, we've got our Chancellor, Nazir Afzal, talking about fighting for gender equality. So hopefully you can all join us there. So again, thank you ever so much. Sheena has just said in chat, there is a Manchester event about tackling inequalities coming up very soon, and hopefully we can see everybody there. But thank you all very much for attending, and thank you to our panelists for joining us.